What I thought I would do is just show you a video of Margaret, who's one of our patients, who's kindly allowed us to show this video, and her husband talking a little bit about her experience of PSP. I think it does paint quite a typical picture of the condition, so hopefully it'll work.
And can I get you maybe just to tell us a little bit about what sort of problems you find day to day with your condition?
The problems I find day to day walking, my left leg is hurting a lot when I sit. I have to stand a lot.
Right.
And also, I tend to fall a lot.
Yeah.
The balance is going very quickly.
Has that got worse?
Yes.
Since I first met you. And when you fall, is there a direction you tend to fall other than down?
No. It's mainly to the left-hand side and backwards.
Or backwards. And have you done yourself any mischief?
Only bruising.
Yeah. Yeah. Okay. What other things? Notice your voice maybe not as.
Dave's not his voice is not as loud.
Yeah. David, from your point of view, you mentioned the voice is quieter.
It's very shallow.
Yeah.
The voice is very shallow, and when she's sleeping, it's very, very, very shallow.
And
she struggles to get in and out of bed.
And you mentioned about the liquids you're needing.
Yes.
Thickener.
Is that because things tend to go down the wrong way?
Yes.
It helps to swallow.
And then the other thing you mentioned was this really irritable bladder and the waterworks, which cause mischief, don't they?
Sometimes she doesn't make it. It's not very far. So for them to it's
not very far away, and I don't make it all the time.
And the last thing, just wanted to just describe, if you would, what you're like when you sit down into a chair.
I plonk onto it.
Yeah, so we were discussing about you being a plonker.
Yes.
And this might be our new clinical sign for this condition.
She slipped off a normal chair, sat at the table, dinner time or something, lunchtime. She sat at the chair, and sometimes she struggles to get on the chair. But just a few times she's slipped and she's gone over the chair.
Right. And if you sit down in the chair, does the chair ever tip backward?
Plus the plump.
Yeah, because you plonk down so hard, the chair tilts.
Yes.
Huh. Okay. And do you have any bother getting out of a chair ever?
All the time. I have to get me reclined to go for nose eyes and candles. And then put both my hands on and then grab my wheel walker that's on 3 wheels and I can put the brake on it and grab all of that.
Okay.
On the windowsill.
That's brilliant.
I'm going to pause it there for a minute. So, I mean, is that a story that people are pretty familiar with? And so there's the kind of the motor problems of PSP, particularly with gait and balance and falls, and the sort of impact that has on day-to-day life in terms of getting out of chairs, getting out of bed, to the loo. There's the sort of speech, communication, swallowing issues, which are massive, and do lead to huge problems, and sometimes the need for things like pig tubes in some patients where appropriate. And we haven't talked very much about our visual symptoms in that video, but that's a big issue. I might talk about that a bit later on. And the other bit that we haven't really touched upon is the personality change. And I know from Sunita's discussions with patients and carers, often it's where we assume it's the falls that are the problem, but for a lot of carers in particular, it's the change in personality of the individual they're caring for, and the apathy and the social withdrawal, or the behavioural change, the kind of verbal aggression and irritability and impulsivity that actually distresses the carers more than the falls, which I think is maybe surprised me when I first heard it, but when you think about it, actually that's very understandable. As a neurologist, aside from the story, I mean, you hear that story, and there's almost nothing else that this can be. And certainly when you've seen patients with PSP, you begin to recognise the pattern in terms of the symptoms and the presentation. The other thing in a proportion of patients that is helpful in the diagnosis then are the abnormalities within the eye movements. And although not everybody with PSP has abnormalities with the eye movements, if they're there, they're extremely helpful. And there are two main things that I find helpful when I see patients. One is just asking patients to look from left to right repeatedly. And those are what are called voluntary saccades. So those are eye movements that we make as animals, as individuals all the time. But in PSP, they become treacle slow. And so normally our saccadic eye movements are extremely quick, and really our eyes come to rest on different targets. And if you were watching somebody move their eyes from left to right, you mightn't see an awful lot other than them arriving at the target. But in PSP, those horizontal saccades are very, very slow. And that's a clue, I think, as to the diagnosis. And actually, that's one of the earliest, in my opinion, that's probably one of the earliest changes that we see in PSP. The textbooks will focus on the loss of vertical eye movements and voluntary eye movements up and down. And I think that, although not everybody has that, if you see that, that is pretty much diagnostic. So this is a video of Margaret 18 months earlier than the start of the video was made. So when she first came to see us, and then what I'm going to do is show you her eye movements today, if that makes sense.
With your head really still, Margaret, just with your eyes, can you look up to the ceiling? And down to your knees. This eye lid up.
So you can see just right now, it's actually quite good down gaze, but restricted up gaze, so she can get pretty much to the midline, a little bit beyond it, but not further up. And now
to the ceiling.
18 months.
And down to your knees.
And so what I would say, she's effectively lost her vertical gaze. No, her horizontal gaze is still good. The eyes aren't actually paralyzed. They can move. It's just that the voluntary signals from the gaze centers in the front of the brain don't seem to be able to activate the reflex, the kind of the nuclei within the brainstem to the nerves to the eye muscles. So that reflex pathway from brainstem out that we use quite a lot just to fix on things that suddenly appear. We don't really think about it, but our eyes move to the target quite often. So reflex eye movements are fine, but you can't voluntarily move your eyes up and down. And that's where this term supranuclear palsy comes from. So all the nuclei in the brainstem and the nerves and the eye muscle, they're all fine. It's the bit above that, supranuclear, that's the problem. I try to teach this to medical students sometimes, and they find it extremely difficult to keep in their brains. So, there's no test at the end of today where you have to get this right. But the reason I'm mentioning that is I'm going to show you now Margaret's vertical eye movements when I do a reflex. And that's called some people call the oculocephalic reflex or the vestibular ocular reflex. But really what I'm going to ask Margaret to do in a minute is look at straight ahead and fix her eyes on the camera. And I'm going to move her head up and down. And so really, she's not thinking about her eye movements anymore. This isn't a voluntary thing. She's just using reflexes and that lower pathway, which should still be working fine, to keep her eyes on a target. And if it's a supranuclear palsy, characteristic of PSP, then the vertical eye movement should come back.
So if you just keep your eyes on that red button, okay, and I'm going to tip your head. Keep looking at the red button. Keep looking, keep looking.
Now can you see that she's able to keep looking at that when I tip her head forward, so she's got vertical eye movements.
Keep looking. Good. And again, keep looking, keep looking, keep looking.
And she's got.
Keep looking at the red. Great, perfect.
Okay, and so that's sort of textbook PSP and the progression of the eye movement abnormalities. And I think it's fair to say that when Margaret first came to see me, she really didn't think that there was a problem. at all. And she just has some very subtle eye movements. And for a moment, I doubted myself in making the diagnosis. But actually, as time passes and as you follow patients up and as you get more familiar with the condition, then diagnostically it becomes much less ambiguous. So, PSP does what it says on the tin. It's a progressive problem. And I would say that the three main things that we see, at least at presentation, are disorders of gait and balance, disorders of eye movements, and disorders of mood and thinking. In terms of gait and balance, I think this is probably why the top two, slowness of movement and problems with balance, this is why this condition is usually diagnosed as Parkinson's disease by non-specialists, I think. And it frustrates patients, I think, that to receive an accurate diagnosis sometimes lasts years, diagnosis of Parkinson's. It's because actually Parkinson's often presents with slowness of movement and problems with balance, and it's far more common, and it's on people's radar. And the difference being, I think, from my perspective, if you, as a therapist, if you've got a patient with a label, a diagnostic label of Parkinson's disease, but within the first year or two of their condition they are falling frequently, then I would have a very serious concern over the validity of their diagnosis of Parkinson's, because it's very unusual for patients with Parkinson's to fall frequently. They can feel unsteady, and certainly in later disease, Parkinson's patients fall a lot, and it's a big problem for us as a movement disorder team. But early falls, that's a bit of a red flag for Parkinson's, a diagnosis of Parkinson's. I have these three things little picture pops into my mind when I see patients with PSP, which is rockets, trees, and chairs, and I'll try and explain what I mean by that. You heard in the video, which is one of the reasons I played it, about the difficulties that Margaret has and the peculiarities that she has when she sits down. And in fact, her husband has screwed a chair to the floor to prevent it from tilting back so precipitously when she plonks into it. And so folk with PSP will often sit down a bit like a tree would sit down. So they're really stiff. They do not bend and lower themselves into the chair. They just thunk back into it. And obviously then the chair tilts back. And we see this in clinic a lot. And diagnostically can be quite helpful. And so as a physio or an OT, if you're seeing that in a patient, that's a clue, again, an early clue, I think, to a diagnosis of PSP. Patients with PSP will struggle to get out of a chair, and Margaret was very clear on that as well. Sometimes they launch themselves out of the chair, though, and that's sometimes gets called the rocket sign. And so rather than struggling to get out and recurrently sinking back into the chair, people will hurtle upwards and then hair off across the room. And of course, if your balance isn't very good, that's not an ideal combination. And so the postural instability and the loss of balance, coupled with impulsivity, and sometimes what's called motor recklessness, is part of the reason I think that patients with PSP fall as frequently as they do. So rocket out of the chair, sit down like a tree, and chairs that rock back when people thunk into them. Those are quite good clues, I think, as to a diagnosis from a gait and balance perspective. And if you're seeing patients with, like I say, have got a label of Parkinson's disease as an OT or a physio or doing a home assessment, and you're starting to see that, then I would seriously consider modifying that diagnosis if I was the clinician. The eye movements we talked about already, really, which are slow voluntary movements of the eyes and restriction in vertical gaze. Lots of older patients struggle to look up. And so just struggling to look up, that's not terribly specific. And you saw with Margaret, though, that actually her downward gaze was pretty good initially, but her vertical gaze was abolished. And for her, she's a young person, she should not have big problems looking up. But the sort of pathognomonic vertical gaze problem is downward gaze, and although patients don't really volunteer, I think you say this, Anita, people don't really volunteer many symptoms from their loss of vertical gaze, but going downstairs can be tricky if you can't look down voluntarily, and I think that contributes to falls as well. And eating meals or reading a book or something where that vertical gaze and that and the saccadic eye movements across text become difficult. I think those are sort of symptoms that we see from eye movements. We don't get many eye movement symptoms volunteered. You have to specifically ask for them. Patients with PSP, one of my kind of interests and what I'd like to do a project in one of these days, is to try and look at the sort of visual symptoms that our patients get, because I think if you chat to any patient, enough patients with PSP, they will often complain bitterly of dry, red, irritated eyes, light sensitivity, often will want to sit with their eyes shut in clinic or at home. And that's difficult for carers as well. The patient isn't asleep, they're not drowsy, just their eyes really bother them, and we have no idea why that is the case. We see a little bit of that in Parkinson's, but nowhere near as much as we do in PSP. And when I last looked, not a single person had asked that research question and tried to answer it. So one of these days, if we get our act together in Teesside, we'll do that. Last thing, and a really big thing, and I think what's come out of Zanita's master's project in particular is our problems with sort of mood and thinking and the impact of that personality change. Patients are often withdrawn, impulsive, and that's impulsive sort of motor recklessness. That's one example of that. I suppose there's a lot of sort of impulse. The other sort of impulsivity we see is in eating, and a lot of patients with PSP will tend to overfill their mouth. Would you agree from when you see this? I'm looking at the speech and language therapist now, but yeah, and that's a big issue, because if your swallowing isn't great to begin with and you're overfilling your mouth, that's not a good combination either. People become snappy, mood can be very low, and emotionally labile, and so bursting into tears very easily, sometimes laughing inappropriately as well, and what's sometimes called a pseudobulbar affect is very evident in clinic, and it can be quite difficult doing the PSP in the CBD clinic. Can be quite an emotional roller coaster for the staff as well as the patients and the carers, and really a very poor attention span and concentration. I don't think we talk about dementia enough in a variety of conditions. We don't talk about it enough in Parkinson's, where it is a big problem, but and Parkinson's can definitely cause a form of dementia. And I think PSP can too. And the D word, the dementia word, I think is shied away from, and we, at least in our clinic, do use that term with patients and carers a fair bit. Not because we want to distress anybody, but because I think if you want to understand why your relative, why your loved ones has changed so much, and it seems to be a different person, then then the word dementia actually makes sense as a way of trying to understand that change. We are at pains to point out that it does not mean Alzheimer's disease, and I think that's one of the challenges that we have, is that there's an assumption that if you use the word dementia, what you're talking about is Alzheimer's, but there are many different types of dementia. Parkinson's can cause a Parkinson's dementia, and I think PSP can cause a form of dementia as well. In terms of why, I'm not going to cover a huge amount about the kind of what's going on in the brain in PSP, partly because I wasn't sure what Hugh was going to talk about, and if he's going to talk about new treatments and things, I don't want to steal his thunder. But effectively, what's happening in the brain in PSP is an accumulation of a toxic protein. And it's actually a very similar protein to that seen in Alzheimer's disease. So it's a protein called tau, T-A-W. And PSP and CBD as well are what we would often refer to as tauopathies. Now that sets it apart from Parkinson's disease, which has a totally different toxic protein aggregating in the brain called alpha-synuclein. And so we tend sometimes, if you read literature on Parkinson's and PSP, you'll see Parkinson's referred to as a synucleinopathy, and PSP referred to as a tauopathy. And although tau isn't the only protein in Alzheimer's disease, and it's probably not the only relevant protein in PSP, it is one of the defining neuropathological features if you look down into the brain. The difference is that the tau is in different areas of the brain in PSP to Alzheimer's disease. So whereas these toxic proteins in Alzheimer's tend to build up in the memory banks, the kind of medial temporal lobes, and the language areas of the brain. So the early presenting features of Alzheimer's are amnesia, rapid forgetting of newly acquired facts, and then slightly later on problems with processing and using language. Those are the big features of Alzheimer's disease early on. We don't see so much of that in PSP. What we see are problems with movement, balance, slowness of thinking, personality change, and I think that reflects the fact that the toxic protein is building up in the brainstem here, and also in this big red bit at the front, the frontal lobes of the brain, and of course that's where our personality, our social niceties and everything else seem to reside. And so if you damage the frontal lobe of the brain, then you alter the person's personality and behavior dramatically. And if you damage the brainstem, then you damage the ability to maintain balance and right yourself if your balance is perturbed. And I think that's why we see those as early features of PSP. So this is the tau protein. What we don't understand about this protein and PSP at the minute is what it is about certain cells that makes them so vulnerable to this toxic protein, because there are plenty of cells that seem to be able to cope with this protein without any difficulty at all. We really don't understand why it starts to go wrong, why it starts to aggregate. We don't know how it spreads. And at the minute, we don't know if we can get rid of it. And I'm hoping to hear from you about some projects, because there's certainly some projects in the field of Alzheimer's looking at vaccines against this protein, looking at drugs that can deplete the protein from the brain. Whether or not those will be transferable to PSP, we don't know. They're many, many years away, but at least we're starting to talk about trying to influence the underlying pathology. What this protein does seems to unravel the sort of microtubular array, the scaffolding of the cells, particularly in the brainstem. And as that microtubular array starts to unravel, cells then stop being able to process and send neurotransmitters properly to the synapses. The energy demands of the cells go up because they're far less efficient at what they're doing. They generate a whole load of toxic free radicals, which then lead to damage and degeneration of that cell, and probably lead to further accumulation of the tau protein, which then leaps across to the next cell and does the same thing over again. And so we get this kind of templating of this protein, and it spreads that way. And any of you that have been past the front desk will have come across Ed's lace. Have you come across Ed's lace? Does that ring a bell? So the PSP associations are promoting at the minute a shoelace with one end is quite healthy and one end is frayed and unravelled, and it reflects this kind of unravelling of the microtubular array of the cells, and that's what's going on. I'm looking at my own shoelaces, which are hopelessly unravelling. Hopefully that doesn't reflect what's going on in my brain. Okay, so that's kind of a little bit about the pathology. It's totally different from Parkinson's. Okay, so not only is it a totally different pathology, tauopathy, synucleinopathy, but it's not all about dopamine, and I think that's probably why PSP patients don't tend to respond well to levodopa, dopamine agonists, the standard sort of treatments that we employ in Parkinson's disease. We don't see fantastic results with those drugs in PSP. We do in some patients, okay, and there's definitely a subset of patients with progressive supranuclear palsy who have a clinical phenotype that is very difficult to distinguish from Parkinson's disease and do have a good levodopa response and probably have a far better prognosis as a result. But the majority of the classic patients with PSP, although we try the Parkinson's drugs, they're not licensed really for the treatment of PSP. They don't really have a huge role, and we often end up stopping them if we don't see much of a response, because we don't want people having to fight to take tablets that aren't helping them. But we do see damage to the dopaminergic system. Okay, this top scan here is called a DAT scan, dopamine transporter scan, and we use that quite a lot in the movement disorder service. And in fact, most of the units will use these to try and diagnose them. But there's hugely different areas of the brain affected, and so this is a slide of the sort of typical areas that are affected, both in corticobasal degeneration, CBD, and PSP is the bottom one. And can you see this red bit of the brain is the frontal lobe, and that's why you see such a huge change in terms of personality and mood and behavior in PSP. Contrast that with CBD, which is much less common. What you're seeing here is damage to the motor areas of the brain and some of the sensory areas of the brain. And PSP patients present in a totally different way. This also is quite close to the language areas of the brain, and so we see a different phenotype in CBD. I'm just going to mention that very briefly. It's another tauopathy. It has big overlaps with PSP, and in fact the PSP association is also the CBD association. The difference, or one of the clinical differences, is that whereas PSP tends to affect both sides of the body equally, which is another clue actually, because Parkinson's is typically asymmetrical. PSP is usually a symmetrical presentation. CBD is the archetypal asymmetrical disease. And if I just zip back to my little slide here, you can kind of see that one half of the brain quite happy, the other half of the brain not. And so that marked asymmetry, that explains that asymmetry, that slide. So asymmetrical onset and persistent asymmetry, that's the hallmark of CBD. And I would basically say, and this is my quote, so you have to take what I say with a pinch of salt sometimes, but I would say if it's not asymmetrical, then it's not CBD. And can you see the slight difference then? So tremor is a big feature of CBD, that's not a big feature of PSP. Significant rigidity of a limb, usually upper limb, but occasionally lower limb. Whereas in PSP, the stiffness, maybe not so much in the limbs, more so in the neck and the axial muscles and midline muscles. Again, slowness of movement in this bizarre phenomenon referred to as an alien limb. The few folk, so there were a few hands went up with CBD. Any of the OTs been looked after or been involved with patients with CBD? Fiona, you're nodding. What did your patient have a kind of asymmetrical? Yeah. Yeah. So leg first and then arm, and carried on with that asymmetry. Probably became a bit more dramatic over time. And what happened? I mean, what could she? What was she struggling to do with that upper limb? And because my experience is that patients just almost lose the concept of the limb. Yeah. Yes. Yeah. Yes. Yeah.
I remember a lady whose arm was affected, and she had to hold on to it, it would just float away, and it would actually cause her to fall over.
Yeah. And that's the typical. I mean, the archetypal alien limb is a sort of levitating, utterly dyspraxic and totally unhelpful appendage, and can levitate. That's what the textbooks would say is a true alien limb. I've seen it a number of times where it will grab onto things as people are walking, or if they're sitting, it will be holding onto the back of the chair, and then when they try and get up, they can't let go of the chair. There are kind of, lay reports even of patients with CBD who, I don't know how true this is, it might be totally apocryphal, who had given up smoking years previously but decided, perhaps not unreasonably, to take up smoking again when diagnosed with CBD, and her alien limb kept interfering with her attempts to smoke off with the hand on her unaffected side. But certainly you can get this concept of intermanual conflict where you're trying to eat with your good side and the other limb then will interfere with that process. So it's so it's dyspraxia, and that's because that motor and sensory cortex seems to be damaged, and so your brain sort of forgets what the arm is for. People often will look with puzzlement at a dyspraxic limb. They just don't really know what to do with it. And when you ask people to try and copy a shape that you show them with your hands, they have no idea of how to manipulate the hand into that particular position. You see a dyspraxia after stroke as well, obviously, which is probably the commonest thing. But I think that alien limb, that very asymmetrical, that very motor and a very jerky tremor, that's typical CBD, and that's very, very different from PSP. So we have a lot of cognitive features in CBD, problems using the limb, which we've talked about, this sort of dyspraxia, apraxia, problems using language as it gets into the language areas of the brain, so sort of dysphasia, low mood, withdrawn, irritable, and effectively the same bottom line. So much like PSP, I would view CBD as forming a cause of dementia, as causing a form of dementia, and again, maybe we don't talk about that enough, that D word enough. They're very uncommon. CBD is particularly uncommon. So give you an idea, so our movement disorder service in Teesside alone, we have about 800 Parkinson's patients under our care at the minute. We have about 45 people with PSP. Would that be about right, Anita? Ish, and rising. Since we set the clinic up with 6 patients 2 years ago, and we're up to 45. We've got about 6 patients with multiple system atrophy, and we've got 1, maybe 2 with CBD. And I think probably those numbers, though that just reflects our local practice, that's probably reasonably representative. So how the heck do you treat this? Well, basically, any way you can. Usually when I do this slide for Parkinson's, I make the neurologists quite small on the slide. With good reason, because actually I think specialist nurses, community teams, the PSP Association, therapists, social services, palliative care, geriatricians, holistic individuals, geriatricians, GPs are far better, I think, usually at providing care for patients with PSP and CBD than neurologists are traditionally. Maybe because I'm a failed geriatrician, and have subsequently had to go to neurology. I'm interested. I'm a little bit more holistic in my thinking, but definitely, I'm constantly embarrassed. We get geriatrics registrars who come to our clinic and they'll see patients, and the stuff that they come up with makes me feel slightly embarrassed for myself sometimes because they're much better out than I am. In terms of medication, there's very little. Okay, and so we will use levodopa, and if we get a good response, we persist, and if we don't, stop it. What else have we tried? We tried all sorts. Amantadine for some of the rigidity in PSP. Don't find that terribly effective. We sometimes use, if people have jerky tremor and spasticity, we'll use sort of baclofen, we'll use clonazepam. We've started using donepezil off license to try and improve balance. We'll maybe talk about that with some of the PSP patients a bit later on, with mixed results, I think. So we'll have a crack at most things as long as it's not unethical to do so, and it seems safe, and we'll keep doing that, I think, until we get some good treatments. So that's my kind of little canter through PSP and CBD. Could we be doing better? Definitely. I think from what have I learned about dealing with patients with PSP and CBD is to link them up with Jenny, who's PSP care advisor, PSP CBD care advisor, on the website, and and the sort of information packs for newly diagnosed patients are really helpful. And I think just being able to link up with other people affected by the condition, and Zanita set up a carer, patient carer group in Teesside for patients affected, and because there aren't many groups around, and I think it is helpful for some people to meet up and talk. One of the purposes of today, I showed this slide last year, so it stopped at 2014, was just to give you an idea of the gulf of research and how much catching up PSP as a condition has to do. But this is just from the 1960s to 2014. If you go into kind of PubMed and ask for citations of articles, trials, and studies published in the field, different fields. This is Parkinson's disease. You can see pretty inauspicious beginnings, and then this exponential rise in studies into Parkinson's disease. Really in the last 10, 15 years, it's rocketed, hasn't it? Here's motor neuron disease, and again, inauspicious starts, but 600 odd studies in 2014 in motor neuron disease alone. And this is PSP down here. And the reason I put MND on this slide is because PSP is roughly equivalent in terms of its prevalence to motor neuron disease. And yet, if you ask members of the lay public about these conditions, hardly anybody's ever heard of PSP. And yet, everybody knows about motor neuron disease. And if you speak to junior doctors, nurses in the hospital or in the community, MND has a very high profile, doesn't it? Whereas PSP slips under the radar. And so days like today, I think, are important. Just trying to raise profile, and I'm gratified to see so many familiar faces as well, because it's lovely to have you all here. So I'm going to tie it up there and hand over to Lou, but I'll happily answer any questions as we're straight through.